Welcome to the audio lecture for self-medicating pain for DPT 623. So the main thrust of this lecture is going to be kind of choices that patients might make in terms of substances they'll use to self-medicate some of their pain. And the reason we want to go over this is that you're going to run into these patients, so having a background or a knowledge of how the substances work, why patients might be choosing to use these, will give you a way of talking to the patients a little more effectively. We also want to include a little bit on how exercise can be used to treat not only pain but depression. So we'll talk about substances, external substances, and then we'll talk about the role of exercise as well. And we will include a little bit on modalities in treating pain. So obviously this is a modalities course. As part of the pain treatment, we'll include some consideration of modalities as well. So here's the topics that we're going to explore: caffeine, alcohol, nicotine, marijuana, then exercise, exercise alone, and exercise in conjunction with modalities. So again, in the past, I've been approached, or students have asked multiple times, how do I talk to patients about substances without sounding judgmental or without it being awkward? So that's a main reason we want to talk about this. Want to help you understand why patients may be using these substances, that someone's not inherently bad because they're smoking or maybe drinking too much, but how this may be affecting their, I guess, coping strategies, ways they're trying to deal with pain and possibly depression. And also some consideration if someone is choosing, a patient's choosing a bad strategy or a maladaptive strategy, can we, instead of just having someone stop something cold turkey or saying just don't do this, is there any way we can replace it with a positive activity? Can we get those natural endogenous opioids from exercise to maybe replace some of what they're trying to self-medicate with? A little bit of a personal story or an anecdotal story, but my college roommate, when we first moved into the dorms, started smoking. He really wanted to quit, but he wasn't sure how he'd be able to do it. So every time he wanted to reach for a cigarette, he went for a bike ride instead, and he was kind of able to replace the bad activity or the activity he didn't want with a better choice. So he got healthier, got in better shape, and basically replaced one thing with another. So I think he was smoking because he was stressed, and the bike ride helped him feel better, helped him alleviate the stress, so that worked. So instead of just stopping something, he kind of had a trigger for why he wanted to smoke or what was causing him to do it, and he found a different activity for that trigger. So let's start off with caffeine. Caffeine itself is the active structure in coffee. Caffeine's present in over 60 plant species, and the amount that's present in a cup of coffee could vary anywhere from 47 to 134 milligrams. Don't need to memorize that, just kind of as a background information that all cups of coffee aren't built the same. A big consideration with caffeine and coffee is that coffee itself has multiple other compounds which may increase the caffeine effects, or it may change how caffeine is utilized in the body. So you'll see in some research studies that they'll talk about, we gave people caffeine pills. Just keep in mind that the caffeine pills may function differently than coffee itself, because coffee does contain these other compounds as well. Caffeine is a stimulant. It's going to increase excitation in the central nervous system. It can also be used to treat sleep apnea in neonates. It's frequently used to treat headaches when combined with other drugs. So Excedrin, I think, is a medication that is used to treat migraines over the counter. It contains the caffeine as well. Half-life, so the amount of time it takes to get rid of half of what's in your system, is about 3 to 5 hours. If you're not a typical caffeine user, the half-life's going to be doubled. So it can stay in the system for quite a while. I just included this because I'm a massive coffee drinker. You see me walking around with my coffee cup all the time. So just think coffee is amazing. So if I were your patient, you'd say, hey, you're probably drinking a lot of coffee, and we'll talk about the pros and cons of the coffee. So the proposed mechanisms of caffeine is it competes with certain receptors in the central nervous system, and it does have kind of two primary effects that may involve what we'll see in patients who are dealing with pain and or chronic pain. So improved vigilance, arousal, and concentration. So if we think for patients maybe that have chronic pain, we think of the neuromatrix, we could see why someone may choose to use coffee. Their brain is typically in a pain meeting. They don't have a lot of mental resources. So using the coffee may actually help in terms of concentration and being alert. The other key consideration is there are anti-nociceptive effects of caffeine. So coffee actually does lower the pain response or the pain experience. It does not alter the dopamine release in the brain, unlike cocaine. So although you may feel a sense of reward in some ways of drinking coffee, you're not going to have the same cravings or the same dopamine response. Dopamine is kind of the reward chemical in the brain, and caffeine does not change the dopamine release. Caffeine can cross the blood-brain barrier and vasoconstrict or cause blood vessels to constrict, and that's why it's helpful in migraine and headache treatment. Big consideration is that the individual response can vary wildly based upon genetics. So we talked about in pain responses that genetics play a big role. They seem to play a big role in caffeine, how caffeine affects each individual. So you've got people similar to me that can drink coffee kind of all day and sleep fine at night. You've got others that 1 cup and they're jittery and bouncing off the walls. So the individual response does vary tremendously. There are multiple benefits and risks, and I will preface this by saying I think in California, coffee or caffeine now has a cancer warning because there is a chemical or a byproduct that is a known carcinogen. What I would say in response to that is that there's so many compounds in coffee that by isolating one as a carcinogen or as a possible cancer-causing agent doesn't necessarily mean that coffee itself increases your risk. So I would push back a little bit on that. There's probably more that's needed, but you may see that in California it's either coffee or caffeine. I think it's coffee that carries now a health risk or a health label warning. What I want to show here is that a systematic review looked at benefits and risks of coffee. They looked at health outcomes, health data. It's a big study, and overall they found that all things being equal, coffee actually conferred multiple health benefits. So lowered all-cause mortality, that means all causes of death. You have a lower risk if you're a coffee drinker. Your risk of death from all causes goes down 12 to 18%. So I mentioned that in California there's a cancer warning with coffee, but according to this meta-analysis, you have a lower incidence of cancer if you're a coffee drinker. So what you have is coffee has a compound that's a known cancer-causing agent, but if you review the evidence or look at the meta-analysis, you actually have a lower risk of cancer if you're a coffee drinker. So go kind of figure that one out or think about that one for a bit. You also have a lower risk of some metabolic, neurologic, and hepatic conditions. The risks are primarily seeming to be in women. There's a higher risk of fracture in women, but not men. And there are some worse pregnancy-related outcomes. Caffeine crosses the placental barrier, and the half-life doubles in pregnancy. So if you're pregnant, you want to stay away from caffeine and coffee. And there is a slightly higher risk in women of fractures with coffee consumption. Wanted to show that this is the chart looking at various health outcomes and risks and benefits of coffee. Don't need to memorize this by any stretch, but as we move into more evidence-based practice and talking about studies and research throughout your PT curriculum, that little bar or that graph in the middle where it says risk estimate, you'll want to know how to read this, and basically that line in the middle means that there's anything that's crossing over that line is kind of on some uncertainty. So anything that's not crossing that middle line, you can say definitely favors one treatment or another. So you've got some that favors no coffee, favors coffee. we'll talk more about this throughout the course, but that's kind of how it's lined up. This is high versus low coffee consumption. Now, what's interesting, I don't know if it's mentioned on this slide or not, maybe on another slide, it does look like you have a higher risk of lung cancer with coffee consumption, but later in the study they tease out the smoking, because smoking and coffee consumption often go together, and when you control for smoking, you don't have a higher risk of lung cancer with coffee consumption. So, and here we go with any versus no coffee consumption. So anyway, just giving an idea of risks and benefits of coffee use. So how does caffeine affect pain? There was a study that looked at 16 college-age women. They rated their quadriceps pain after intense cycling, comparing caffeine to placebo. And they also looked at the role of anxiety and pain. So it was kind of a two-pronged study approach. So what they found in terms of pain intensity, and you can see on the graph on the left, is that caffeine definitely modulated pain, or patients had, or the study participants had, lower pain reported responses. Also with the caffeine, if someone ahead of time had what was described as a low anxiety sensitivity, so they didn't score themselves as highly anxious, caffeine had an even stronger pain effect in terms of lowering the pain level. If someone rated themselves as high anxiety sensitivity, then the caffeine had much less of an effect on pain, and that's the graph on the right. Cochrane review. So Cochrane will take meta-analyses, looks at as much evidence as possible, labels things as high or low level evidence, and they found that there is improved pain relief adding caffeine to pain medicine or analgesics for acute pain. Analgesics plus caffeine gives you a 5 to 10% improvement in pain relief, and this is high quality evidence. So you got someone that's using a lot of caffeine trying to manage pain. There actually is evidence that caffeine is going to have anti-nociceptive effects. It may be helping their alertness. It may be helping them concentrate. So, and there are a lot of positive benefits to the coffee. So something to keep in mind as you're talking to your patients. Cortisol. So we've talked about cortisol, the HPA axis, and what's happening there with that kind of adrenal response. So cortisol responses can be diminished, but don't completely go away with moderate doses of caffeine. That's 300 milligrams a day. We said a cup of coffee, I think, was between 40 to 100 something. So that could be anywhere, depending on how strong the coffee is. You're talking maybe 3 to 7 cups of coffee, which is a pretty wide range, but that's moderate doses. So if you go above 300 milligrams a day, that HPA cortisol responsiveness can go away or be abolished. Daily caffeine use at moderate levels gives you an incomplete tolerance to effect on cortisol, but individuals likely have varying reactivity to caffeine. So this is important. So I've kind of set the stage that moderate coffee consumption or drinking coffee does help with pain, maybe makes you more alert, but too much caffeine, too much coffee, could you be messing up the cortisol system and having now adverse effects because of how cortisol is not working? Absolutely. So you probably don't need to get patients to stop drinking coffee, but you may need to have discussions with them about monitoring how much coffee or how much caffeine they're using. Big consideration here, though, with this study is that the authors used caffeine pills or placebo pills, not coffee. So I would also wonder how it might be different if it was coffee versus the caffeine pills. So to summarize with caffeine, there are anti-nociceptive effects. Coffee does appear to confer multiple health benefits, with biggest risks being for women. Risk of fractures does go up, and women in pregnancy have increased risk of adverse events if they drink coffee during pregnancy. There's probably differences between caffeine and coffee given the other compounds in coffee. So when you look at studies that are using caffeine, keep in mind those outcomes might be different than if they had used coffee. The response to coffee and caffeine likely has a strong genetic component, especially when considering HPA axis and cortisol. In chronic pain, Coffee may help for anti-nociception, but the other thing to consider is sleep hygiene. So if that patient is drinking coffee around the clock and is not sleeping at night, that might be another discussion to have, or that may be an intervention that needs to happen so the patient can improve sleep hygiene. All right, we'll move on to nicotine. And nicotine is an active compound in cigarettes. Nicotine is widely recognized to have analgesic effects, so it will decrease pain. They think that this happens via nicotine acetylcholine receptors, both in the peripheral nervous system and the central nervous system. And nicotine can also improve attention. So you may, if you've worked with or know any smokers, they feel that having the cigarette improves their attention or vigilance, similar to coffee, and that's where you also get maybe the coffee and cigarettes going together. You've got kind of the central nervous system stimulated by using both substances. So I kind of already told you this might be important in chronic pain because you've got a pain meeting going on, you've got someone who has a hard time focusing, so having improved attention would be something that the patient's looking to have. Wanted to show this picture of MRIs showing the areas of the brain that are lit up or working when someone's using nicotine versus placebo. And rather than being in a pain meeting, this is showing how more areas of the brain are active when trying to do a task. So it's showing that you actually get improved, not improved cognition necessarily, but improved attention. Don't need to memorize this slide at all. It's just showing various ways that they theorize that nicotine is involved in analgesia. So we've talked about kind of different levels according to Lundy-Ekman, excuse me, levels 1 through 5. And so this is just showing where the nicotine can bind on certain receptors and where the pain modulation would be occurring. So here in this diagram, we've got the receptors that are active in the dorsal horn. So that would be, we'd say that's at the level 2. And then we also have receptors that are in the brain. So here we're talking probably level 4, where those nicotine receptors are modulating pain. So smoking could potentially be working at levels 2 and level 4 in terms of pain modulation. So same as caffeine. I mentioned caffeine's not the same as coffee. Nicotine is not the same as smoking. Smoking is usually used as a means of ingesting nicotine, just like coffee is used as the means of taking in caffeine. So although nicotine has analgesic effects, smoking itself carries multiple other considerations. Smoking is linked to the prevalence of many chronic pain conditions. So smoking doesn't cause pain, but there seems to be an association with many chronic pain conditions with patients who smoke. Smokers tend to complain of higher pain levels. Smoking is associated with higher rates of depression. And there's a psychosocial consideration because of how areas are moving towards not being, this is tobacco-free campus, or you can't smoke within 50 feet of this area. Smokers are tending to be marginalized, forming isolated social clusters. So society kind of looks down on smokers. They're not valued. So you've got all these other considerations, and then generally, psychosocially, smokers get marginalized. So here's a diagram and all the ways that smoking can actually adversely affect the chronic pain experience. So you see the psychosocial factors, the depression, the other effects, structural damage to systems. Definitely something to consider is that there is impaired wound healing. The circulation is going to be impaired. It's not something I've explicitly put on the PowerPoint, but wound healing. So let's say someone had a surgery, they had a laminectomy, a back surgery. They actually are going to heal slower if they smoke. So we're talking about this chronic pain, or we're talking about smoking from a kind of psychosocial or neuromatrix, but there are physiologic considerations with smoking as well. Even though we said nicotine has analgesic effects, prolonged smoking can change the way these receptors function, so they're not going to be as effective down the road. So that's what they're saying with the desensitization and upregulation, neuroplasticity, and pain pathways. Pain-induced reinforcement of smoking behavior. So you're going to have a lot of altered pain processing that, even though the nicotine helps with pain, this prolonged smoking is actually going to worsen the pain response or the pain experience. So nicotine does have analgesic effects and can boost attention, but smoking itself is associated with higher pain levels and increased risk of chronic pain. Marginalization of smokers might contribute to the pain and depression as well. All right, let's move on to most people's favorite topic, which is alcohol. We got Ron Swanson after having a little bit too much to drink. So in contrast to caffeine and nicotine, so it's going to dampen down or inhibit how the nervous system's working. So it inhibits multiple neurotransmitters. The breakdown product of alcohol is likely just as important in brain effects as alcohol itself. In acute alcohol use, you're going to get a hit of dopamine. So your brain you're getting the brain's reward system to light up. With prolonged use, you're going to develop tolerance, and that dopamine, how it works and how it's produced, is going to change. So you're going to have a hypodopaminergic state. So you get a reward, you get a reward, you get a reward. Now you're not producing as much dopamine, you're having to drink more to get that same reward, and that kind of starts the cycle. So alcohol is inhibitory in the nervous system. It basically dampens down or inhibits responses. What this table is showing is that over time with alcohol use, the central nervous system is continually inhibited, such that if someone attempts to stop alcohol use when they've been using for, I'll just say, too long, or when they've been using excessively, the nervous system now is in a very excited state because that alcohol use the body's gotten so used to that inhibition that the body itself was producing more excitation to try and maintain homeostasis. And this is why you may see people who are in the hospital for acute alcohol withdrawal. You'll see seizures, you'll see other difficulty, and that's the nervous system being too excited, and so that excitation is overwhelming any inhibition because you've removed that external inhibition. So throw this slide in there because you might see on clinical rotations patients who are going through alcohol withdrawal. You'll see seizures, you'll see activities of the nervous system being too excited, and that's because that external inhibition from the alcohol has been removed. There is an analgesic effect of alcohol, so alcohol absolutely can help with pain. A systematic review documented was well documented to have analgesic effects. A 0.08% blood alcohol level, which depending on weight, gender, etc., 3-ish, maybe 3 to 4 drinks, reduces the visual analog scale pain rating by 1.25 points. So if you get kind of buzzed or you're on your way to getting drunk and you're having pain, your pain level, how you're going to report your pain, is going to go down. That's documented. Each 0.02% increase in BAC gives you a 0.2 improvement in your visual analog scale. So bring this up. We're not saying that patients should be drinking alcohol to manage pain, but if they tell you I drink to manage the pain, it absolutely can work. There is a pain response, or a lowered pain response, with drinking. I worked with a gentleman who drank a fifth, I want to say it was tequila, drank a fifth of tequila, I think, every 1 to 2 days to manage his pain. Said the pain medications he was getting weren't working, we weren't taking his pain seriously. So I tried to talk to his doctor about it. I mean, it's challenging. You don't want patients to be on opioids for an extended period of time, but you've got someone who tells you they're drinking just huge quantities of alcohol to manage the pain. That's not effective or working either. So this is pretty challenging. So another study looked at, I think, patients with chronic widespread pain and also fibromyalgia, and there actually is decreased disability with increased alcohol use. So these patients that had this chronic widespread pain all over their body, the more they drank, up to a certain point, the less disability they experienced. So what they found in this population, that the disability was worst if there was non-drinkers or those that drank more than 35 drinks a week. 35 drinks a week would average out to 5 drinks a day, so you're almost talking about a 6-pack a day. Above that level, you had worse disability. But anything under that, anything between a few drinks up to 34 drinks a week, these patients actually had lower disability. Now the problems though, so you can have someone who's choosing to self-medicate with alcohol for pain, and that would actually be an okay strategy from a pain perspective, right? We've got studies that say your pain level is going down, you have lower disability rates when using alcohol. There's a lot of problems with that though. The greatest analgesic effects are with doses exceeding recommended guidelines. The guidelines for quote-unquote safe alcohol use keep changing and coming down. I believe that most recently anything more than 14 drinks a week for men, and I want to say 7 for women, puts you in a category at risk for alcohol use disorder. So they keep kind of scaling that back. A recent study in the Lancet came out saying there's really no safe level of alcohol use because of risks of health problems, accidents, etc. So again, that's kind of that cost benefit, or how we talk to our patients, is it makes sense they may want to be using alcohol for pain relief, but there's really not a lot of safe dosing for alcohol, and they're going to run into other health problems. So if you've got a heavy alcohol user who's self-medicating pain, I hope you understand why they might be doing it. They're not a bad person. They're trying to get through the day. Our challenge or our difficulty is figuring out, well, how can we get them to decrease their reliance on alcohol? Are there other things we can be doing, healthier options, so they don't hurt themselves or put themselves in bad situations? 30-year longitudinal study looking at alcohol use in the brain found that prolonged alcohol use is associated with reduced right hippocampal volume in a dose-dependent manner. So that means that more alcohol that was consumed, the worse this finding was. Higher alcohol consumption also resulted in lower white matter integrity. More than those 14 units per week, so a unit is a unit of alcohol, a shot of whiskey, a can or bottle of beer, associated with cognitive decline and brain pathology. So that's not a high dose, right? That's 2 drinks a day, and higher levels than that, you're already looking at an increased risk of cognitive decline. Now, these are facts that you're probably not going to be able to use very well with patients. They probably don't care about 30 years down the road or way down the road if they have dementia or cognitive issues. They're suffering, they're in pain today, they're not going to be able to see down the road. But I just present this as well as something both for your patients and for you to keep in mind, that even low levels or low doses of alcohol can give you these adverse cognitive effects down the road. So for alcohol, well-established analgesic effects. It absolutely can modulate your pain. It makes sense if patients are trying to manage their pain. There's actually well-established effects for disability with widespread pain. Problem is that quantity needed to effectively kind of treat or manage pain exceeds recommended dosing. So it may help treat the pain, but their patients are putting themselves at risk for a lot of other adverse effects. Increased alcohol use is linked to multiple poor health outcomes. So just to kind of keep this in mind, we know alcohol and smoking are bad in the long term, but as I mentioned before, how effectively do you think patients in pain can consider the long term? I mean, let's think back. I keep going back to the example of you in class during like finals week, that you're probably not eating as well as you should. Maybe you're skipping workouts, or a lot of healthy behaviors you may have go by the wayside during finals week. You're just trying to get through the week. So at that time, if someone tells you about things down the road, you don't even want to think about it. You just got to get through the week. So that's trying to tie that into maybe personal experience. But for patients, they don't care about 2 weeks or a month down the road if they're suffering. They got to get through the day. And if any of you have been in high levels of pain, you know how time kind of changes. So each second that ticks by seems like a day when you're dealing with significant levels of pain. So at that point, anything that helps you is going to be an effective strategy for you. So I say this to caution about educating patients about the bad or adverse long-term effects of what they're doing, because that may not be something that would help with behavior change, because they're just trying to get through each day. All right, so I want to touch briefly on marijuana. Here, I was not able to find a lot of evidence, and I think a lot of that's due to legality. So the laws are changing with marijuana, but how legal it is still varies by state. You're not always going to get accurate information. So I want to present to you what I was able to find in terms of pain modulation with marijuana, but keep in mind there's not a whole lot of evidence as of right now. So there are a variety of effects from cannabis. There are anti-nociceptive effects. This is going to be, again, generally inhibition throughout the nervous system. So hypoactivity, cardiovascular changes, everything kind of slows down. The mechanism of action is thought to be binding and further activating cannabinoid receptors. And let me skip back, sorry about the jump here. So that's really all I've got on marijuana, just because of the lack of good evidence on it. So you can get anti-nociceptive effects, and more evidence will be coming out. I can't tell you 100% fully the risks and benefits of marijuana. So let's skip ahead to exercise. So we talked about substances that patients might use to self-medicate pain. I'm going to propose that exercise is a way of self-medicating for pain. It's using those endogenous opiates. It's kind of that level 4, maybe even level 5 of pain modulation. So Cochrane Review said that exercise is an intervention with few adverse events. And I want to keep this in mind, that exercise is generally safe, because if you get those patients who are dealing with chronic pain, they will feel that exercise can harm them. They may feel threat from exercise. So you'll need to think about exercise is safe. Yes, if someone's having pain, you want to keep an eye out for that, but in the absence of actual tissue damage, or in the absence of actually causing harm, I would encourage you not to tell patients, well, we'll stay away from pain when we exercise, or don't do it if it hurts. You're now encouraging avoidance behavior, or you're reinforcing to them that they're fragile. So if you've done your clinical exam, there's no structural damage, yes, the person's hurting, our prescription is generally going to be exercise as therapists, and we need to ourselves understand we're not hurting the patients if they're exercising, and we need to try and get the patients to understand that as well. Now, modalities, I threw in here, this is with low back pain, I believe, the summary on the left. Heat and cold for low back pain, not a ton of evidence, maybe some for heat. But if you use heat with exercise, it gets a little bit better. So that's where, as we go through modalities, Dr. Kinzel and I will talk about, we can do the modalities, but we combine them with exercise. They'll also have a stronger and a better benefit. There is limited evidence for most modalities. I'm lumping them together. We'll hit the individual modalities in the course and find that, okay, there's going to be stronger evidence for one in this particular situation. So standalone treatment, though, not a whole lot of evidence. There is evidence for use of modalities as an adjunct to exercise, so use it with exercise. And again, that would encourage a more active participation by the patient instead of just passive recipient of the modality. I would argue that based on the mature organism model, think back to that, think how we're always scrutinizing for threat, that modalities could help in lowering the perceived environmental threat. And they could be useful in altering some of those painful inputs. So remember, we're taking in cues from the environment, from our own tissues, we're scrutinizing, we're thinking about threat, and then we change our outputs. So the modalities, I think, can lower that environmental threat. They may change some of those tissue perceptions, and that might be a way to modulate the pain experience. I think, though, if you only use those modalities and you haven't changed any of the patient's behaviors, you haven't done anything active, then the patient's kind of a passive recipient, and you're probably not going to get long-term changes in pain behavior. So I think modalities are useful, but I think Dr. Kinsel and I would both say don't make them the end-all be-all of your treatments. Use them to change some of the inputs as part of an overall treatment plan. Talked a little bit about this before, but this concept of painful exercise. So if you have someone has had back pain for a year, normal MRI, you've done your exam, no structural damage, and they just really don't, they say, oh, when I do this it hurts, or I can't do any exercise, and you say, okay, avoid anything that hurts. Think about what you've just done. You've just reinforced their avoidance behaviors. You've told them they're fragile. You've reinforced them to scrutinize and to be vigilant about anything that hurts. So I would say in these cases, we as therapists or as student physical therapists need to change even how we think about it, that there's the pain that hurts and pain that harms. Pain that harms is actually doing tissue damage. If it's pain that hurts and there's no tissue damage, these patients would benefit from exercise. So us telling them don't exercise or stay away from it, we are not helping our patients out. Two main strategies with exercise that you'll see in the literature and that we'll talk about in this class and in others are graded exposure and graded exercise. So graded exposure is safe exposure to activities that provoke pain or fear. So let's say that I have back pain, I'm fearful of bending forward. I say if I bend down as far as touching my knees, my pain level goes up to a 5 and I hurt for a half hour afterwards. Okay, so then as a therapist you might say, well, can you bend forward to touch your mid-thigh? Yeah, I can do that. Okay, that's our starting exercise. We're going to do that. Let's do, whatever your prescription might be, a set of 10, 2 sets of 5, whatever dosing you want. Patient does that, says, oh, that doesn't hurt. What you've now done is you've changed the memory of bending forward. Now, granted, we don't have full range of motion, but the patient is starting to see that bending forward is not a threatening activity, and over time you would progress to being able to bend further forward. So that would be graded exposure. Another example would be someone who can't lift, let's say 20 pounds. You start by having them lift a pound or 2 pounds, giving them success at an activity, and you keep then challenging and going further with exposure to the fear-provoking activity. Graded exercise is, you may also hear it called quota-based exercise, that, again, without any evidence of structural damage, the patient will be put on an exercise program and they progress on the program regardless of pain level. So maybe you have me on a walking program, I do 10 minutes today, I come back later in the week, my pain level went from a 4 to a 6, you'd say, okay, no, all right, but I'm going now 12 minutes on the treadmill. So regardless of the pain response, you're going and continuing through the exercise. Both of those, by the way, have been shown to be beneficial treatments. Here's a study where they looked at 33 patients with chronic low back pain. They were treated with either graded exercise or graded exposure. Both groups showed clinical improvement, and their reductions in pain and disability were associated with reductions in depressive symptoms and pain catastrophizing. So both strategies are effective. In this study, the graded exposure was maybe a little more effective. It wasn't clinically a significant difference between groups, but a little better pain response in graded exposure, which tells me that a lot of the pain was probably coming from fear beliefs and fear avoidance. So I could do a whole separate presentation on multiple studies and the benefits of exercise for pain, but I want to keep it simple for this presentation. Huge amounts of evidence on the benefits of exercise for pain. Our take-home message to you, and what you'll hear in the pain science discussions at like CSM or through the pain science literature, 20 minutes aerobic activity at 50% VO2 max is going to give you pain reduction. And the pain relief extends beyond the treatment time. So this tells us that the area that is being effective is probably that level 4, maybe level 5. Level 4 for sure, endogenous opiates. So this is where the active aerobic exercise is superior, let's say, to some of your modalities or some of your treatments whose pain benefits stop as soon as you stop the treatment. So something that's, let's say, the gait control theory, you're stimulating a faster moving nerve to close that gate. Well, as soon as you stop stimulating that nerve, the gate opens and the pain comes back. So the endogenous opiates, the pain relief from that is going to last longer. You're going to have a sense of self-efficacy or a sense of, wow, I can do this. So that changes the brain at multiple levels. Hard part is it's difficult to get some patient buy-in with this, right? And we'll talk more about how to do that throughout the course. But if you're looking at your prescription of exercise, 20 minutes of aerobic activity, 50% VO2 max. You might not be able to calculate VO2 max, or you might put a patient on a walking program and they don't know how to calculate VO2 max. It's probably reasonable to then say 50% of max heart rate or use a rate of perceived exertion scale. So if you can't get it to be an exact science, I want to give you some targets you can shoot for, and a lot of it will depend on how you describe it to the patient, how specific you make the goals, and how much buy-in you get. You can start with fewer minutes and work up. So this could be, you don't need to stop at 20 minutes because there is evidence that more time might give you a little better effect. There's also evidence that a higher intensity gives you a better pain effect. So these are kind of your basic goals to start with. But if a person can't do it, that's fine. You say, you know what, we're going to do 5 minutes today, and we're going to see how you do. But that might be the person you put on a graded exercise plan and say, every time we're going to go up a few minutes. And then you may still have to scale. Well, if the pain goes up tremendously or something happens, you still may have to work with them, but generally put them on a graded exercise program. Strength training is absolutely beneficial. The role in pain modulation is not as clear, though. So you're probably going to get some self-efficacy. You may get kind of level 5 improvements in terms of cognition or how they're feeling. It's unclear to me whether you get those endogenous opiates. So you will hear in the kind of the pain science world, there's a huge preference for the aerobic exercise. But I'd say if you get someone that wants to do resistance training or likes to lift, you could include that. And I'm just thinking you could also do possibly some circuit training. So you're getting that heart rate up, you're making it aerobic with some resistance training as well. So we know that depression is closely linked to chronic pain, so I wanted to include in here a little bit about exercise for depression. Very strong evidence that there's significant improvement in depression with exercise, and there is evidence for both aerobic and resistance training on their own. And the effects, though, are stronger if combined. So if you have someone that's willing to do both strength training and aerobic training, they're going to get better improvements in depression by doing both. The optimal dosing can't be determined because the study designs are different. So I would say you have someone maybe with chronic pain and depression, use your 20 minutes, 50% VO2 max for aerobic, build a resistance training program that they will like, and I think you're well on your way. Wanted to include this study. This is a study by Blumenthal et al. That reinforces that exercise is a viable treatment for depression. They ran a series of studies known as the Duke Smile studies. Aerobic exercise was compared to antidepressants. Interestingly enough, here the aerobic exercise was at a pretty high level, 70 to 85% of heart rate reserve. So again, the responses do seem to be somewhat dose dependent. Higher intensity is probably going to be a little bit better. So we're saying start at that 50% VO2 max, but here we've got groups that were exercising 70 to 85% of heart rate reserve. So there was the similar levels of improvements in depressive symptoms between the groups that exercised and those that took the medications. What I want to point out here, though, is that the exercise group had a lower relapse rate at 10-month follow-up. Also at the follow-up, the only significant predictor at 1 year of whether someone was going to be depressed or not was exercise. So there was a decreased depression in exercisers. Antidepressant use was not a predictor of depressant symptoms. So this is huge. You've got, as you're working with patients or talking to them, oh, I just want to take a pill, and here I'm going to have my anti-medication stance, but You treat someone with a pill or exercise, in the short term going to be the same, but what happens in the long term? Exercisers are going to have superior outcomes. And I think our current medical system unfortunately doesn't tend to follow people long term. We get that short term treatment. Let's get through the day. Here, this is going to help you. So you might have physicians that say, well, the medication's just as good as the exercise, but long term it's not. And if you explore on your own or look at try and find through the evidence, I don't know that they've looked a lot at long-term outcomes of antidepressant use. A lot of people get put on these medications, and I'd have to go back in the literature and really check this, but I believe they weren't really investigated for long-term use. So us being PTs, we definitely have a bias, but the evidence kind of supports our bias that exercise actually in the long term is going to be superior to medication for treatment of depression. So that's pretty powerful. So if you're treating someone for pain, you know the exercise is going to help anti-nociceptive effects. But if they have that depression as well, boom, your exercise is treating that as well. So you've got a treatment, you've got a prescription with your exercise that's just as, if not more effective than medication. The trick is getting patients to buy into your medication because it doesn't come in a pill form. Here are the multiple proposed mechanisms of exercise on depression. Don't need to memorize all these, but just pointing out that there's many ways that exercise is beneficial. So you don't need to kind of explain to patients all of these, but pick a few of these as you're talking to patients, put them in patient-friendly language, and kind of figure out a way how you can help make that sales pitch for exercise. So a lot of listed like physiologic factors, definitely improved sleep, for sure improved self-esteem, increased ability to handle stress, analgesic effects. So many positive benefits of exercise on depression. So to summarize, we've looked at a lot of ways that patients or ourselves can medicate for pain. A lot of these are substances we may choose to take in that have some positive effects regarding the pain, but a lot of them are associated with negative health outcomes. Exercise is a natural painkiller that also has antidepressive effects. So keep in mind, I've tried to place all of this in kind of a physiologic, biopsychosocial kind of domain. So we're thinking about the substances that are quote unquote bad, and can we replace those with exercise, or think about the way exercise is good. I'd like you to think at a higher level than, oh, patients should exercise, I'm telling you what to do. Now hopefully you understand how exercise affects the brain, how these substances affect the brain, so you get an idea of why the patient's choosing one direction and how we can maybe get them to change and choose healthier strategies. Modalities can absolutely play a role in patient management with pain. I would say use them as an adjunct to exercise, use them to lower the threat, and use them to change the patient input. The big, I guess, caution I'd advise is an over-reliance on modalities might encourage the patient to be more passive. And throughout our treatments of patients, we'd like to encourage an active role. We'd like them to not shrink back and view everything as threats, but we'd like them to assume responsibility for their care. So, but modalities definitely can play a role in managing pain. Finally, patients deserve open and honest communication. If your patient says, well, I'm smoking 4 packs a day, I'm not a smoker. I don't know if that's a lot or not, but you will want to have the conversation about smoking. And that conversation I don't think is helpful if it says, well, you shouldn't smoke. You might say, how long have you been smoking? Do you find that the smoking helps you manage your pain, or are there other benefits you're getting from smoking? So if I ask, how do you feel smoking is helping you? I'm asking the patient to think about it, to give a response, and maybe they'll say, well, I don't know that it is, but I'm putting the ball in their court. We can have a discussion about it and see if there's any way that I can help them, versus I say, well, you need to stop smoking, it's not helping, here's a referral for the smoking cessation program. Yeah, I don't know about you, but if someone talked to me that way, that's not changing my behaviors at all. If, on the other hand, we have that initial discussion, I've talked openly with someone, and they've asked me, hey, why are you smoking? What is it benefiting you? And I say, it does help with the pain, but in other ways I feel more tired or more cranky. I can say, okay, have you thought about, changing how much you smoke? Are you interested in? And I'm kind of a leading question in a way, but I'm, again, asking them to take responsibility for it. That's a much different discussion. So as these substances come up or these maladaptive strategies, don't shy away from these discussions. They deserve, our patients do, to have open and honest communication. But to have that, you need to be comfortable yourself with your thoughts and your biases on these substances and people who use them.